Well, hello, everybody, and welcome to this week's edition of the AHA podcast, Advocate Health Advisors. And today we have a special guest, Mike Yasi, handling the West for Advocate. Welcome, Mike.
Well, thank you very much for having me. I appreciate it. I'm looking forward to the conversation.
Yeah, it's great to have you. And Alyssa's taken some well-earned time off, having not just a birthday, but a visit to Ireland. So she's got
Nice.
a Blarney Stone to visit and other fun things as we move into the summer and take the well-earned and well-needed vacation. And, after we get to July, the pace quickens and it's already here for AEP.
Sure does.
So, Jacqueline, why don't we start with you? I saw the energy and commerce in the legislative branch under the House. There are two different legislative bodies that oversee Medicare. One of them is Ways and Means, has a health subcommittee, and Energy and Commerce. I believe Guthrie now runs that. And he formerly ran the healthcare subcommittee. And today they had a little bit of a conversation about transparency and 11 different issues. You want to give us some highlights there, Jacqueline?
Sure, yes. Energy and Commerce had, I think it was a 3-hour hearing today with several witnesses regarding healthcare price transparency, and multiple topics were discussed, like site neutrality payments, also getting price transparency as a factor to making healthcare decisions, right? To know the price upfront before you agree to receive services, and some other transparency factors like more data sharing for health plans. They even brought up the subject of agents and brokers too, and talked a little bit about their compensation, which I thought was interesting. And we got to hear from an incoming MedPAC commissioner, Benedict. So that was also interesting to hear some of his comments as well. And there was a study that keeps getting brought up, and the one that was brought up, which I thought was interesting, was a JAMA study on trends in broker commissions over from 2014 to 2022. And they had a Brown University health economist there speaking to it. So we've been looking at the study pretty closely, and noticing some serious faults into that. So look forward to revealing the truth per se, because that was obviously teed up for that hearing.
Yeah, it's unfortunate, but you kind of glossed over Benedict. So I think the MedPAC rep did a solid for the brokers, and he said, if you're trying to get after Medicare Advantage or Medicare program improvements overall, that lever isn't going to really do much for you, right? He was saying
That's
that
right.
messing with brokers is hard. It's not going to yield much fruit, and it's already been tried.
That's right. So that was refreshing to hear. We also I looked at the study a little bit more closely, and it's so interesting, how they calculated those things too. For example, I was just seeing that they're looking at MA broker commissions from 2014 to 2022. They applied 2024 fair market value assumptions for those past years when they didn't even exist yet. And those commissions, changed by 30 to 40%. So I think that's just very telling of this study and the nature of it too. And also, they applied a inflation adjustment for 2025. We know the last 10 years, inflation, has made an impact too. So, this study, unfortunately, isn't sound.
Well, with all the wonderful academics we have in the world, I'm surprised that it's so hard to get rigorous, activity. It really discredits the point when you see the way that the work was done. But more, we'll get back to that at another time. It's clearly, um, an opportunity for us to come to the table and commission some studies that are rigorous and that have
I think so
multi-factors
too.
to
Yeah, you have
triangulate.
to look at the source too of who commissioned that
Yeah.
particular
That's right.
article to be published and study. It was, I don't know,
Well,
Jacqueline, if you want to say if it's worth mentioning, but
no, I think we'll move on. So, Jen, I saw some news on Social Security potentially running out of money a few months sooner. Did you see that?
I did. Yeah, I haven't read the whole article yet, but I do know that you and Jacqueline had sent it over, so I'd probably be better off to come from one of you guys, but I'd be curious about it.
Yeah, well, the highlight there is that there's cost pressures on the industry, starting with the Social Security Trust Fund, and it looks like it might not last quite as long as we had thought for a variety of factors. But Mike and Jacqueline, wouldn't you say that most people pay their Medicare, fees out of their Social Security check as opposed to a credit card or some other way?
Yeah, it's
Yeah,
most convenient. Go ahead, Mike.
yeah, I was going to say that is the preeminent method that money is taken to support that is right out of their Social Security. So Part B in other ways is funded that way. So, but yeah, that's a huge concern, and they've been talking about that fund running out for years and years and years, and they just can't quite put their finger on exactly when. But it is just one of the other pressures that is facing the government, facing the consumers, facing the carriers, and it all lends itself to the annual dialogue around what can be offered to consumers in the way of a Medicare plan, and how rich are they, and how do consumers access those benefits, and what is the actual cost for that. I think we have seen those costs taking years to be actually accounted for. And so unfortunately, it seems to run a couple of years in arrears before they're actually, they actually arrive in the consumer's inbox, if you will.
Yeah, it's funny. It always amazed me too how long, corporations report on a quarterly basis. I get anxious at Advocate if I have to wait more than a couple of
Yeah.
months to see the stats.
Yeah.
Jennifer, along the lines of cost pressures on the country and on Social Security, we saw one of the companies file bankruptcy recently.
Yes, I see a lot of news out there about that, and I saw some social media posts as well. Go Health, which is one of the larger legacy call centers out there on the Medicare Advantage side, did file Chapter 11, which is out there as public record. It's interesting because we've been probably talking about this for a long time. You can see this in the public records as well on the quarterly earnings, but the if your cost of acquisition on a sale is greater than the commissions that you're bringing in, that's a
The
sign.
lifetime value. Yeah.
And if your lifetime value of the sale continues to go down, that's also a sign. So I think there was those pressures for a very, very long time. So it's not surprising to see that just because of what we know about the industry and the math, but it really points to sort of where we are as an industry as a whole with Medicare Advantage, in that, the carriers are looking at quality. We've got to add lots of value out there. When you look at the metrics of lagging indicators of quality that you always talk about, meaning like, your rapid disenrollment, your accretion rates, your complaints to Medicare, your retention, those are signs, right? And those metrics the carriers have, and those metrics are not as, they can not be as good for certain organizations, and they can be a lot better for others. And we really need to all be on one standard. I just made a little comment on one of the posts out there about that. I just think, if you have a local community broker that is known in their area and they're building trust, as you always say, retention starts at the sale. And, it's not that we can't meet the members where they are if they want to enroll over the phone. It just means that we need to be considering, those
Absolutely.
metrics. Yeah.
I would echo what Jennifer just said, and add to it that Um, that the Medicare Advantage and Medicare market in general is maturing, right? It's changing quite a bit. And agents who are or were selling on the flashy benefits of the OTC card or the fancy gym membership, those days are pretty much going away, and they must now be an advisor. They must actually know all of the different nuances of each of the plans locally, and the provider groups. You can have a provider group that's online and shows as in the network, but are they accepting new patients? And what are the changes in the local market? And so that call center model for quite a few of those groups has been one of selling on the change to an OTC card or a flashy benefit. And they don't have answers in some cases to what that local nuance is. And so I think you're right. You're spot on that the local licensed community-based agent is really the place to get what information is needed to present to a consumer. And the advocate, I think, has been well placed for 20 years that we rely on that local community based agent to be the sole source of that correct information. And as we know, licensed agents for advocate train hundreds of hours to hone their craft, and we recertify every year. And I don't know that you get that in other avenues. So I think it's time. Its time has come, I think.
Yeah, I think it's a quality issue. I used to see it just from the distribution channel perspective, but I think that's a little bit short sighted. The reality is we want to get a certain level of quality, and beneficiaries should have the chance to, kind of call, click, or visit, right? Whatever distribution channel they prefer to utilize, they should have the opportunity to utilize it, but they shouldn't suffer a big quality hit. And so when you have entities that 30% of what they submit never accretes because their accretion level is 70% or below, and 20 or 30% rapidly disenrolls, that's a problem. And when half of what you submitted at the beginning of the year isn't there at the end of the year, that's not profitable for the carrier. That's not profitable for the organization. So I think the challenge to the industry is to step it up. And whether you do that through a community based broker infrastructure, which I am admittedly partial to, um, I think that I think that the industry has to go there, and the carriers now, because it's really a story of financial pressure, right? The carriers are under financial pressure, and we're going to continue to see that. And that means that they're looking deeper. It isn't a land grab anymore. They're having to be
Yeah,
more
that's right.
selective and more careful. And we saw that in GoCo, and we saw the contracts that were terminated. We saw Humana term significant and not allow them to recontract. So as they learn, to look deeper into the numbers, they're making decisions. And, we've seen other carriers do that too. Mike, I want to go over to you on a little bit about DSNP, because one of the earlier financial pressures we saw was when the state Medicaid rules had changed and some of the DSNP program. So could you tell us a little bit about that and where it is today with the Medicare, with the dual eligible population?
Yeah, so we are, well into the mandate by CMS that all dual eligibles be on an aligned plan, and CMS has given a certain number of years to make sure that dual eligibles enrolling in a plan are enrolling not only in the carrier that provides the DSNP plan, but that same carrier must also have the Medicaid contract in that state. And so we are seeing a funnel effect, if you will, whereby in each state there are fewer providers of a dual special needs plan because they aren't giving out those Medicaid contracts to just everybody. And so those carriers are now being forced to prove their worth when it comes to handling complex issues and providing some long term care and some behavioral health and other elements that are desperately needed by this population, right? And so, what we're seeing in the market is fewer but stronger carriers when it comes to the dual SNP population. And so, over the coming years, you will still see more of that alignment, whereby we know of two significant types of dual SNP plans out there. There's your FIDE plan, your fully integrated dual eligible plan. That's your Cadillac of D-SNP plans that provides proof that they have viability when it comes to complex care issues. And then your highly integrated dual eligible plan. That's a little less, and it's not as strong as a FIDE plan, but ultimately most markets have one or the other. I equate it to a minivan versus a Cadillac, the FIDE plan being the Cadillac. And so agents have done a wonderful job, as you can see by our sales numbers, and I'm sure sales of our competitors, in adapting to the structure of these plans and what a member must have to qualify for them. But I think it's better for the consumers. It's better for the carrier. The alignment allows for a greater amount of any kind of debate over the care. It's now one party handling the debate on both sides, Medicare and Medicaid, where in the past it wasn't uncommon for the dual provider to say, well, that's a Medicaid issue, go talk to the state. And now they can't really do that because they are the owner of both sides. And so it's, I think, better in the long run. And I think we're just going to continue to see more of that alignment. It boils down to educating agents who are able to educate consumers and find those who are eligible that fit either into the Heidi or the Fighty bucket. I think the carriers love that product. It's a high revenue product for the carriers. And every carrier call that we are on, we see more and more dialogue around wanting dual SNP sales. So I'm happy that we embrace it, and I think our numbers reflect that.
Yeah, yeah. No, we're doing good as a company, and a lot of that's thanks to you. The better story in that though is that these structural changes still leverage prevention to beat cure for the most vulnerable people, and DSNP and CSNPs. A lot of the opportunity comes because they're managed better. The administration is more efficient. The coordination is more efficient. And when you look at the national averages, where 200,000 and 300,000 people a year die needlessly from what they call quote unquote medical errors. When you dig down into that study, like Jacqueline and I have done, they're not really medical errors the way that you would think, where a doctor made a mistake. It's quite often, an administrative error, a failed prevention opportunity, a failed coordination opportunity. So it's just the complexity, which hits the dual eligible population much more harshly.
Yeah,
Well,
for sure.
Mike, one of the things that we were talking about before the call was some good news around GLP-1, and so
Yeah,
could you talk a little bit about what's happening there with the meds?
I sure can. Great news, actually, out of Medicare. They have launched a demonstration project that runs from July 1 of this year through the end of December of 2027. And it allows Medicare beneficiaries who have either a Medicare Advantage prescription drug plan, an MAPD, or a standalone Part D plan to obtain three GLP meds that are currently approved. CMS is saying they could add more to it. Zepbound and Wegovy, I think that's how you say it. Those are two of them. Uh, a a a potential user of, they call it the bridge program, a potential partner there, it simply goes to their doctor. The doctor will submit to the government a prior authorization. They start submitting those on July 1. They cannot submit them any sooner. But ultimately, it provides the Medicare beneficiary a $50 flat copay per month for the use of those GLP-1s. The pharmacy will simply collect the $50 from the consumer. The pharmacy will bill the government for the balance. The dollars don't apply to any max out of pockets. They don't apply to any deductibles. It is a true standalone, if you will, demonstration project. There is some medical requirements that go with it. They must have a 35 or greater body mass index when they start the treatment. They can have a lower body mass index, but they must be associated with a condition like a chronic heart failure, kidney disease, diabetes, pre-diabetes. So people can get it with a smaller body mass. But it's an exciting program. I think a lot of people will take advantage of it, and more to come on that. But they should be adding additional GLP-1s soon.
Yeah, well, thanks. Yeah, a long time ago, someone I respect, Toby Cosgrove, the former CEO of the Cleveland Clinic, he said, and he wrote a book too, smoking and obesity are what's killing the country. And, so taking that on squarely is a good thing. And the reason
Excellent.
I wanted you to highlight that is because there's a lot of good news stories out there. Sometimes I hear the different conversations, and it's sort of a sky is falling sort of
Oh,
syndrome
yeah.
out there, and it's not blue skies and apple pie, but it's as one of our carrier partners said, it's partly cloudy. So we got a little more disruption. But those GLPs, the science. There's so many moving parts, right? They're changing the overall rules of the program. The economics are impacted. They're making people now have to work to get Medicaid, and it's more tumultuous than it's ever been. And I think that's going to continue. Jennifer, what do you think? The rumblings I hear are that there's going to be continued non-commissionable plans. There's still going to be service area reductions. We're not out of the woods yet, but there is some logic to it. And I wonder what you're hearing, Jen.
Yeah, I mean, this is a topic that's come up. I think we've even talked about it on one of the other podcasts, but I think it's relevant to talk about it today just because we see other carriers that are announcing, commission reductions and things. And so, I would just say to what I tell agents and agency partners is like, to your point, the sky isn't falling. It's just cloudy. They're trying to, use the best do the best they can at designing these plans where they can make money, and we're going to see a stabilization. I mean, we'll have another little bit of a bumpy AEP this year, but I feel like we'll have some stabilization. The Medicare Advantage program is strong, right? We have 35 million people on it. It continues to grow. And I think if we all work together, we can be successful. And that starts with, the agents working with the beneficiaries and doing a proper needs analysis, right? It starts with the carriers just put all their bids in for at the end of May. We don't really know what that looks like because they have to be really quiet about that, But we'll start hearing things coming out over the next few months, and we'll be ready to help agents with strategy and a plan. And so that's what I'm hearing.
Well, yeah. Well, I think you're right. And I think it's important to point out the virtuous cycle of Medicare Advantage. You mentioned that they have to make a profit, but the carriers, they make such a small profit, right? I mean, it's a lot of money. And I don't mean to trivialize, the billions of dollars, but for probably 3 or 4% profit, they've created this competitive and national infrastructure, which were a key part in the service and in the distribution. And people really, I mean, the pendulum's kind of pulling back now, but think about it. Vision, hearing, dental, they've created thousands of dollars a year in additional value through competing and through innovating these private companies with terrifically high levels of satisfaction. Like, people love Medicare Advantage. That's why it's over 50%. And if you ask people what they like, they like the program, and they're going to flock to the program. And the other point that you hit on is that the Medicare population is here to stay. They're going from, upwards of 60 to 80 million in early 2030s, and then they go up to 100 million by 2050. So, the pressure on Social Security is because we don't have as many young people coming in paying Social Security as we have people, exiting. I think I heard Dr. Oz say, if you just work one more year before you retire, and it'll help the fund, and since we have pretty tight labor markets right now, that probably is something we can echo, and we're seeing seniors really enjoy working with other seniors. So a lot of our agents, the average age is coming up on 60, which is kind of fun. um, so Jacqueline, back to the study. Did it look to you like some of this work at the legislative area, it's sort of reverse engineered? Because the timing was a little bit
Mhm.
coincidental to me, that they would have a study that maybe said something that they wanted to say. Uh, what do you think on that?
Yeah, I think the timing was a little bit uncanny that a study would be published so close to a hearing regarding this subject, and they just teed it up in a really superficial way. I just hope that usually people that uh, come out, they have the PhD title, they present the study. Still do your due diligence and read the study. It's not a long study on JAMA, and I think that there's a real opportunity to work with CMS, maybe the carriers, to really get some, uh, objective data out there on what it really looks like. So
Well, good job digging into that, and I think that we will see more focus on that area. So I think that's a good thing. And you personally have reviewed the files, right? Didn't we talk last time that there's 126 contracts out there, and virtually 99% of them filed to use a broker in the enrollment process.
that's right. There's an agent broker compensation file that's public by CMS, and uh, 171 parent organizations for MA plans filed intent to use agent or broker. It actually also includes independent brokers in there too. So that's public, and we see 99%. use those plans. And the study actually used Freedom of Information Act to request the internal version of from that report to CMS to look at some of that data too. So we kind of know what data they're looking at and how they're doing those calculations too. So I'm definitely piqued my interest to take a look at that.
I thought it was interesting of not what they put in there, but what they left out of there, because the information they provided was really out of context. They
Mhm.
mentioned the $10 billion that's spent on broker commissions, but they didn't talk about the number and just how large it is, right? When you talk about that much being spent, it's, what did you say, Darwin? $1.52
Yeah,
trillion
it's like
dollars.
some small
That's
number.
it's a small number. And they
And the
didn't show
industry
that.
itself is 4.6 going on 5 trillion. Yeah,
Yeah,
the
Right.
Medicare and
such a
Medicaid
low number.
component is a subset of
Yeah.
it, but
Population also grew tremendously. So with that trend line for broker commissions, I would have liked to see the trend line for Medicare enrollment too, and then also use some and not apply a fair market value numbers that did not yet exist during those years as well.
well, and
Exactly.
Medicare Advantage and ACO models are the way ahead, right? Because prevention beats cure. And so, I mean, think about it. We didn't have GLP-1s 10 years ago in the way that we do now. And now it's a game changer. We're addressing one of the biggest threats to the population and all the things that come with it. And so, as those new things are possible, these programs are innovating that. And CMS working in a public private partnership with these private corporations is how you do it. There's a lot of controversy now over private equity and the ramifications of that. And setting public companies, private equity companies, setting all that aside, the private sector is good at certain things. They're good at satisfaction, they're good at efficiency, they're good at innovating, and the government is good at certain things. The government sets the vision, they set the guardrails. It's challenging, but they need to set the metrics and they need to be the facilitator, right? They need to be the convener and set that environment. And so our current administration at CMS is doing that like it's never been done before in my 30-year career. So I'm
I think
happy
the
with that.
I think the GLP-1s is a prime example of that, Darwin, in that this new administration is providing rapid deployment of a demonstration project that will make a difference to the outcomes of the seniors. And I think this is a reflection of that for sure.
Yeah, and even the automation, sharing records, having visibility. Now, I think that with AI and all the technology, I think they're going to hit a wall, but they're spot on when they just say if you're interested in being active as a participant in your own health, which you should be, and you're active in the benefit structure of the plan and unlocking those benefits, that ability to see the information and to act on it is fantastic. And I think that that is job one. Now, there's going to come a point, though, where we've got the information, and the second wave is going to be modifying people's behavior, right? The non clinical factors, behavior, environment. There's things that impact health outcomes, and quite frankly, more non clinical things impact health outcomes. And that's the whole value based care model is you catch it when it's a symptom or you catch it when it's a behavior before it becomes a multiple chronic conditions. And so as we continue to do that, I think it's going to really continue to benefit the society. And I think that when I buy wind insurance in Florida, knock on wood, it's hurricane season now. It doesn't lower my probability of a hurricane coming. It does give me a financial safety net, but these Medicare Advantage plans, they actually reduce the probability that some negative health impact is going to happen. And that's why I do it. That's what I love about it. And with that, I can't believe it. We're already out of time. So thank you, everybody. Thanks for
Yeah,
joining us, Mike. Great
my pleasure.
insights. And
My pleasure.
look
Thanks for
forward
having me.
to hearing everybody next week on another version of the AHA podcast.
Yay. Thanks, everybody.